Good morning, good afternoon, and good evening, friends. Thank you very much for joining this international webinar series jointly organized by CAHO and ISQua. Indeed, it's a pleasure to have you all from different parts of the world joining us for this very interesting webinar that's going to be on clinical indicators. And this is going to be the last webinar of the season. And with this, we break for our holidays, hopefully, unless we are going to have another wave of COVID that's going to bash us. Hoping that nothing happens and we are all going to be very safe. Let us continue and listen to this very interesting webinar from all the way from Ireland. Dr. Philip Crowley is going to be handling this session. And thank you very much for joining us and the partnership with ISQua for this amazing series. So we will be meeting you in January as well. We are going to be starting the next series again with ISQua. So wonderful array of speakers for you next year. Now, without much delay, let me introduce the moderator for the day, Madam Gracy Mathai. I don't think she needs any introduction for the audience in India. Madam Gracy Mathai is a very senior healthcare professional, a friend and a mentor to most of us in the journey of quality, safety, and accreditation in this country. I think most of us have been trained by Madam Gracy, and she is currently the CEO of Baby Memorial Hospital, very senior principal assessor of NABH, member of various committees of the accreditation body in the country. So over to you, Madam Mathai, for moderating the session and for taking us through this wonderful webinar. Over to you.
A warm good evening to all of you, and good morning, good afternoon, wherever you are. Thank you, Dr. Allu, for that wonderful introduction. I am really proud to be over here. Just a brief about today's topic. Clinical indicators are tools used for measuring a process or outcome. Quality improvement and the use of clinical indicators is about analyzing processes, identifying what changes could be made to improve the process, and establishing a plan to make improvements. It's not about assigning blame for an ineffective process, but is about determining what can be done differently to improve the outcome. Drawing from the work of Edward Deming, quality improvement principles include a strong focus on patients, continuous improvement of all processes, whole practice involvement in the pursuit of quality, and use of data and team knowledge to improve decision making. The other word, quality, clinical indicators and quality improvement are side by side, two partners. With this, I just would like to introduce our today's speaker, Dr. Philip Crowley. Dr. Philip Crowley is the National Director of Strategy and Research in the Health Services Executive, Ireland. He's a graduate of Advanced Training Program in Healthcare Delivery Improvement. He leads a national team that supports the health services in improving care through the application of a framework for improving quality. He's a doctor who works part-time as a GP. He worked for 5 years in Nicaragua, trained in a public health in Newcastle upon time, and worked for 6 years as Deputy Medical Officer in the Department of Health. He has been in his current post since 2015 and worked in the Health Services Executive since 2011. He will be talking to us on continuous quality improvement through clinical indicators. Over to you, Dr. Philip Crowley.
Thank you very much indeed, Dr. Mathai. Our flags are so similar, India and Ireland, just we put ours on the side. And we miss your spinning wheel. And I'm on the board of ISQua, and I've been to India many years ago. As a student, I was in Delhi and I went around the country a little bit, and I have strong feelings for India and the region, and so it's very, very nice to be with you today. A few things about myself, just to build on what Dr. Mathai said. Yes, I spent 5 years in Nicaragua after I trained as a GP, and that was really a very seminal time for me insofar as what it showed me, I think, was the power of communities to improve their own health. A very strong community movement in Nicaragua at the time, which I worked with, and they developed all kinds of health programs to improve the health of their population. They did it themselves. We supported them. So it's something I kind of carry with me throughout. Then I spent some time training in public health in Newcastle, where you can see the soccer team there, who are not very good, lose all their matches. But anyway, that was a time when I worked in the NHS and learned about the NHS and the free at the point of care service that they provide there, which is a very admirable service, I must say. Coming back to Ireland, then, as Dr. Mathai said, I worked in the political system as a deputy chief medical officer for 6 years, and learned a lot, I suppose, about the politics of health. Something that that you can't separate health from politics at times, and sometimes that can work very well. Sometimes it can be more complicated. In terms of my general practice, I work with the homeless in Dublin, and most recently, I've been co-leading the public health response to the pandemic, and I helped set up some of the vaccination programs there, and I participated in them as well. Our health service is, very, very well funded, you could argue, but still very much under pressure. This is not an untypical scene of overcrowding in our emergency departments, not a dignified situation for patients, and one which we are working very hard to try to overcome. Particularly now with the pandemic, these are our case numbers over the last year or so. No more than yourselves, we've been having our difficulties with this pandemic, and it's been a very intense nearly 2 years now. I think all of our staff are very exhausted from the experience of working around the pandemic and trying to deal with the additional demands, adapt our services. We've used quality improvement to change how we deliver care, to virtual clinics, to clinics out in the community, to all kinds of new ways of delivering care and compartmentalizing care, keeping COVID patients separate from non-COVID patients. But that's not always possible because you don't always know if somebody has COVID, obviously. And obviously you can see we're well into our third wave here at the moment. It's kind of stable at the moment at a level that we prefer it to be lower. We have still pressure in our intensive care units. We have a 93% vaccination rate, which is great for Ireland, but I'm very mindful of the vaccine inequity globally. And I think our government is quite prominent in trying to push for, we've been certainly sharing vaccines with other countries, and I certainly believe that we need to vaccinate everybody before any of us are safe. So hopefully the global program will get the proper support that it requires so that everybody can get vaccinated. We've had a successful vaccine program. Obviously, the new variant is something that's unpredictable at the moment. I wouldn't be claiming to share any particular analysis of the new variant with you. I'm sure you're very aware of the emerging evidence on it, but it's certainly very, very different from previous variants. And we have to see what effect the vaccine has on it and how virulent the virus itself is. So what about measurement? I've been working in quality improvement for so long now. On the one hand, I believe measurement is really, really important. If you don't measure something, you don't know if you're having an effect. On the other hand, we can create a terrible burden of measurement, and we can get kind of bogged down in measurement, and we can end up measuring almost for measurement's sake and spending so much time in measurement, we don't give enough time to improvement. But I think it's important to say that the reason we have QI and the reason we measure is because if we have a true innovation and change that we want to institute, we can't tell if it's going to be effective if we don't measure it. And we have QI because great ideas don't always work. There's a whole series of papers that show fantastic ideas that on the surface of it should have been a great success. And when implemented at scale without testing it, using QI method in other words, they did not work, and an awful lot of energy and effort was wasted. And quality improvement was given a bad name by just going ahead with kind of mass implementation without testing something in the first place. So measurement is not improvement in itself, obviously, but it is necessary to say, did we achieve an improvement? And as I said before, you can have a great idea, but it doesn't necessarily work. So we have to test and measure it. And that's why QI methods come in, and the work of Deming, as Dr. Mathai has already referred to. So part of the ways to structure what we might measure is obviously the Institute of Medicine's domains of quality. Is our care person-centered? What's the question there? Do we ask patients what matters for them, rather than just imagine that we know that already? Do we individualize our care to people's individual needs? Is our care safe? Are we measuring harm? Do we know, are we harming people? Is our care effective? Do we give the right treatment every time, all the time? Is our care equitable? Something very important to me, I must say, the whole issue of equity, and I'll come back to it maybe in a minute, but are our service equally accessible to all people? Is our service timely? Clearly in Ireland, it is not timely. We have significant delays in access to outpatient appointments for specialist care, and we have a program of work to address that. We have a lot of work to do. You would be very shocked at the delays in access to care in our health service. Is it efficient? Are we getting value for money? Are we avoiding waste? I remember Don Berwick came to Dublin and we met him, and he was head of the IHI at the time. And he gave a talk on professionalism, and he said one of the primary professional responsibilities is to avoid waste, is to get value for money. And I think sometimes it's something that we kind of forget because we're so focused on patient care, we don't always assess the opportunity cost of spending money on one thing rather than another. And I think that is a responsibility and something we should measure. In terms of equity, in Ireland, we have various subpopulations in our population who do not really receive equitable services. And that's something that we should be very concerned about and measure. So we have a community group in our community called the traveling community who move around, and their health outcomes are poorer than the general population, and we are concerned about that. So what about displaying the data? So it's one thing to kind of have measures, but I feel very strongly about how we display our data is really important. Edward Tufte, who's written a lot on data display, is quoted as saying, the only thing worse than a pie chart is several of them. And you can see in the cartoon here that, as you can see from these full color charts, we're spending a lot of money on toner. These kind of charts, they can be useful up to a point, but I believe there are better ways of displaying data. So on the left-hand side is commonly used ways of displaying data. Obviously, the bar charts there on the left, the green, amber, red chart there in the middle, these bar charts, not forms of visual display of data that I would be supportive of, whereas instead we're trying to move our service. I'm not saying we've achieved it. We have a lot of the type of display on the left there. We're trying to move our health service into displaying data more intelligently on the right, with statistical process control charts and funnel plots. And funnel plots with the names of the hospitals names, so as you can identify who's who. So in the HSE, I think that's our health services, national health services. We're coming down with data. We have loads of data. Can we make sense of it all? Sometimes, maybe not. We have a lot of tables of data like that you see there. We have the red, amber, green. We have some run charts. We've arbitrary targets at times. Large volume of data. Very limited analysis of the trends over time. And really, we compare, say, for example, our performance today with our performance this month last year. So a point in time today with a point in time previously, often with no sense of what's happened in the middle. So there's no sense of trend over time when we look at it that way, and that's not good. And this often I found leads to people overreacting to data and saying, oh, we must act on this, and we must do something about that, we must change this, when in fact it's only a point in time data and may not in fact represent something that's significant and may not really be a signal of anything at all, because there's been no statistical control applied to the data. So the Duran trilogy you may be aware of when to measure. You can measure when we're planning quality services. We've talked already about the importance of measuring during an improvement process to see if the improvement is working. And then we continue to measure to see if we've established the improvement as an ongoing process, or if, is it in control, or is it reverting back to poor control, to more variability. So integrated care measures will cover things like, well, we have done obedience, structure, process, and outcome, obviously, but we would add to that culture. I believe if we don't measure culture, we really don't know what's going on in our health service. We don't know what environment healthcare is being delivered in. And I think it's a crucial thing to measure, and it's not easy to measure. But in structure, we can measure kind of numbers of staff in given areas. Is it the number of staff ratio? Is it safe? Are we delivering training programs like the training programs that you deliver through CAHO? What kind of management infrastructure we have? Is our IT up to scratch? And what's our finance? Are we going to come in under budget or not? They're kind of structural measures. Then process measures, we can measure the clinical processes. We can measure integration across services. We can measure reliability. We can measure governance. Our services being properly governed, because when things aren't properly governed, things go awry. And then obviously the kind of the holy grail is outcomes. And we have a number of measures of health and wellness. We've just published today our Healthy Ireland survey. We do a survey of health in Ireland, and we just published our 2021 survey today. And it shows various trends that shows that we need to be much more serious about prevention in our society in terms of people being overweight, lack of exercise, smoking, and all the other risk factors that you're all very aware of. So we measure that, and that's an outcome. That's an outcome we need to change. And then clinical outcomes in terms of access. We have lots of access measures. Clinical outcomes in terms of success, morbidity and mortality. We have a national audit of hospital mortality, which we publish every year. And it's interesting, you might think in publishing an audit of hospital mortality, you might have a lot of media controversy, and our health service is constantly scrutinized by the media. We're never out of the media. I'd say we're in the newspapers every single day. So it's quite a burden of scrutiny. But when we produced this audit of hospital mortality, interestingly, we had patient representatives with us, because patient participation is crucial to everything that we do. And we dealt with the media straight up front, totally transparent, very clear about where there were issues in terms of excess mortality. And there was no controversy whatsoever. So I really believe when even you deal with sensitive and potentially controversial data, when you're fully transparent and you involve the people who experience the services, you can manage the message very, very well. We obviously measure harm. We have a national review constantly updated of adverse events, an adverse event reporting system, and that's analysed on a regular basis. We're working towards patient-reported outcomes. What matters to patients? Their experience. And we do have a patient experience survey that we run every year. And then value is another outcome. And then in terms of culture, we have staff experience surveys, patient experience surveys, stories as well. I'll come back to stories, and just measuring culture as well in general. I think the culture of the environment in which we deliver care is critical to the type of care that we end up delivering. So what are the key components around measuring for quality? Like, as a public health doctor, I suppose I love measurement. I kind of feel, let's measure everything. I want to know everything. I want to measure absolutely everything. But of course, that creates an amazing burden for the people who are developing the measurements. So we really should only measure what matters and what we're going to act upon. And we should be selective, and we should prioritize. I believe in complete transparency in sharing what we measure with the public, with the media, on our website. All of our data on the pandemic has been put up online. And one of the key things we need to look at, and Deming was very big on this, is measuring variation and trends over time. You measure variation through things like funnel plots, so you can see if someone's an outlier. You can also see, not necessarily in a bad way. And this is not, I think, as Dr. Mathai very aptly kind of emphasized at the start of this is not to blame people. This is not to say you are failing and you are succeeding. And we're going to cut your funding because you're failing, or whatever we might do as a kind of a punishment. No, it's really to look at performance in general, to look at, and when you look at it over time, what you're doing is you're trying to look for signs of improvement, not failure. If somebody is a significant outlier positively, you then try to learn from them. Because I think there's a real trend now in patient safety to learn from when we succeed as well as from when we fail. But we need to constantly build in our services the capability to measure and particularly to analyze the data so as we can support improvement. Because if we have the data there sitting there and we don't analyze it effectively or properly, and we don't create the charts, the visual representations that we need, it's very hard really to improve care then. There are many pitfalls, but two common pitfalls in relation to measurement I find anyway is trying to improve something that doesn't need to be improved or over which you have no control over improving. So in other words, somebody says this situation here has to be improved. It's politically important or whatever, but actually we haven't really looked at it and analyzed it and said, well, actually we don't really have many levers over that. We don't have much control over those outcomes, and we set off trying to improve it, and that's doomed to failure really. And the other key pitfall, I think, is not involving subject matter experts from the start and thoroughly throughout the measurement process and throughout the improvement process. So that subject matter experts and service users should be involved in every improvement project throughout. And before we decide what to measure, they should be involved as well. So what can we use indicators for? The thing that people hate in our health service are league tables. They hate the idea that they're going to be measured as to say the endoscopy, the rate of endoscopy getting around, you say colonoscopy getting around to the cecum. That's a measure of quality that we have. What they don't want is to see their name in a league table and that they're bottom of the league or lower part of the league. They don't want to be compared unfairly, particularly when sometimes there are variables in people's practice that that explain where their performance that isn't explained in a league table. So they should document the quality of care. They can provide a benchmark from which you then try to improve, rather than a benchmark to say you failed. And then you can make comparisons over time. And you can monitor performance, you can monitor the effect of investment. Like when our government just recently agreed the budget for next year, they're going to expect us, and I'll show you how we're going to do that, to demonstrate how we use that investment, the taxpayers' money in the end of the day, to improve care for our taxpayers and our patients. There is an element of accountability and judgment, I guess. We have an independent regulator who constantly scrutinizes and criticizes our healthcare, and it can be used for accreditation, as you well know. It should be based on a standard of care, however. There must be some kind of a standard against which you're measuring. Otherwise, you might just be kind of making it up. But ultimately, it must be directed at learning and improvement. And then it really starts to be worthwhile. So a clinical quality indicator, because I don't really separate clinical and quality at all. It should be obviously an indicator of quality of patient care delivered. It should measure in a valid and reliable way. So when other institutions use the same measure, they are comparable. Otherwise, you can't compare. Like if people are adopting measure in different ways, you can't compare to institutions then, and then you don't know who's doing better and therefore who we can learn from. It needs to be relevant to something that's important to us. As I've already laid out the important Institute of Medicine building blocks of quality health service: effectiveness, safety, efficiency, and also particularly important dimensions of care like professional care, organizational care, what the organization is doing, and patient-oriented care, of course. We should be choosing measures that are relatively feasible to gather. Our health service is under enough pressure without us coming up with great ideas centrally saying, let's measure this and let's measure that. This is a great thing to measure. Why don't you measure this? We have put no thought into whatsoever how easy it is to measure that, how much of a burden on somebody who's already significantly overworked, how much of a burden it represents to them. And we must involve patients, the people who use our services, to define the kind of outcomes to ensure that we develop meaningful measures and ones that the patients find important as well. So this is an example of some old data that we would produce in our performance report. And I use this to show to our own management team some of the pitfalls of displaying data in this way. So this is things like waiting for funding for home support so they don't have to go into a nursing home, outpatient waiting list total. Well, that's interesting. That's an interesting trend over time, and you can see it's going in the wrong direction. Emergency department waits over 24 hours. I don't know what it's like in your hospitals, but this is a significant problem, as I showed in the earlier picture. And then physiotherapy access within a year. Can you believe that community access measure is within a year? The target, you'll see there, was 98%. You can see with all of them, basically the performance is kind of a straight line. So the interesting thing about the physiotherapy one is we brought the target down to meet the performance rather than performance up to meet the target. So that demonstrates that really this measurement has not really done anything. We've been measuring this over that's a year-long period of time. And what I'm suggesting when I put this to our management team is look at these measures over time. And I ask, have we accepted this performance as the norm? It seems like we have, because nothing's changing. In fact, it's getting worse in some instances, but certainly not improving. So what's the point in measuring that at all if we're not acting on it? And certainly, what's the point of bringing a target down to the performance? Was the target wrong in the first place? Or is it just admitting defeat and saying, well, our performance will never meet the target? That's what it seems like to me. So look, these are some of the pitfalls of data. And certainly if we have data where there's nothing changing over time, you have to ask the question, either should we be measuring it or should we be doing more to improve? Probably the latter is the true answer to that one. So clinical indicators can be misused in all kinds of ways. We can focus so much on the indicators and the performance around those indicators that we forget to actually care for patients. We kind of rush patients through. We don't care for them truly. We don't give time to empathize with our patients because we're so busy meeting the target. Outcomes measured against clinical indicators can dictate or impose levels of safety or quality or pay for performance purposes. It can be used for reasons that we don't pay for performance. That's not how our system is developed, but it can be misused, I think, sometimes for that, and therefore skew our care to particular measures and not others. It can be used for disparaging people, for criticizing. I don't think that's a good way of motivating people to improve. Not a good thing to do. Using indicators that are not supported by evidence are not important safety and quality risk driving unproven and inappropriate clinical activity. And we've had examples of that in our health service in the past, and we've rooted that out. So we have an indicator looking at something that actually is a form of care that is not evidence-based. If by measuring it, we're promoting it. So we shouldn't be promoting something that's not evidence-based. And finally, the classical thing with having a set of indicators and targets is you get gaming and tunnel vision. And we have had examples of that. Tunnel vision is where we just focus on the care that we're measuring here. So we focus on hip replacement surgery because that's what we're measuring. And then we forget about knee replacement surgery altogether. And that might be greatly disimproving, but we're only focusing on the measures that we're actually showing in our report. So that's tunnel vision. And the other thing that can happen with measures, particularly if we operate them in a punitive way, is you can get gaming. And that's frequent, where people, I remember when I was in the US studying quality improvement, they had the Veteran Affairs scandal where they were being measured, their access for the veterans to their outpatient appointments was being measured. The authorities noticed that the performance was significantly disimproving. So what was the response of the authorities? They were under so much pressure from the political system to deliver to that performance, they knew they couldn't without further resources. What they did was they took people off the waiting list and put them into a parallel waiting list, a kind of a shadow waiting list, a ghost waiting list. And then they brought the numbers down who were waiting in that way. But they didn't achieve any target. It was gaming. They gamed the data. They got away with that for about 6 months, and then somebody noticed it. And then the entire senior management all had to resign. So gaming isn't a good idea, but it's a frequent response to when people put under pressure around performance and indicators. So I think we should be very wary of how we use the indicators. So there are different levels at which we can use indicators. We can use it at when we're just doing a small measurement of change, a PDSA cycle, when we're in our own ward or our own clinic, and we're trying to change a small thing, and we do a test of change. We measure it to see did the change work, and if it didn't work, then we change the intervention until we find on a small level that it did make the change, and then we go into a quality improvement project and we start to implement that change at a wider level, and we measure again at that level. And then at the level that I work at the system level, we have all kinds of measures that we measure for improvement there as well. So there's different levels at which you measure for improvement. So to give you a couple of examples of what we're doing at the moment in Ireland to try to measure intelligently, I suppose. The first thing is trying to move on from that slide I showed you with the sheets of data, the point in time compared to the point in time in the previous year. We're trying to move to use statistical process control charts and funnel plots to look at variation and identify special cause changes and special cause variation. And this is all encompassed in a thing called that we're calling the National Quality Profile. It's using existing data but reporting it in a different way. So as I say, SPC charts and funnel plots, and not red, amber, and green. So the information should describe changes in quality and care used over time and is used to promote interventions that we use to improve care. So the SPC charts can reliably distinguish signals, in other words, something that's actually significant change from random variation. Because when you look at any healthcare data, it bounces around. So when it bounces up, we shouldn't be celebrating because it's only random variation. When it bounces down, we shouldn't be getting depressed and worried about it because it's only random variation. But if we apply a statistical process control chart, we know if it's bounced outside of what we might expect by random variation. And that's a signal. And when we have a signal, we should act on it. And that's why the statistical process control chart is so valuable. So we find then, as a result of this, the healthcare leaders are better informed by having access to information that they can make sense of and that they can act on. So for example, here we have some of our, this is just examples taken from our quality profile. So there we have staph, bloodstream infections from Staph aureus. We have return of spontaneous circulation in the community for cardiac arrest. But these are just examples of measures, but what I'm really trying to show here is that the way we display it is very intuitive. It shows up here on the right upper line the desired direction. We want this to go down. We want hospital-acquired bloodstream infections to go down. We can say if there's a funnel plot that goes with it, so we can see what the variation is between different hospitals, and we can see if there's a signal, and indeed there is in that we color it differently. So it's very easy to read. The percentage of all attendees age over 75 and over at ED who are discharged or admitted within 24 hours. This is the third one here. You can see all kinds of trends there. There are rules that determine whether something is a trend, and the number of sequential data points that are go in a certain direction, and you can see twice that those criteria have been met, and that creates a signal. And in here we're saying the average national performance is worse than the target, and it's also unstable because it's fluctuating around. So we interpret the data for people, but with time, when they get used to looking at the control charts themselves, they learn how to interpret it themselves. So it's very intuitive, very clear, and very much, if you like, facilitating action. Here's some other ones. Hip fracture surgery within 48 hours. If somebody comes in with a hip fracture, they do much worse. They're not operated on really within 24 hours, but at the moment we're measuring to within 48 hours. And again, there was a trend there, which we noticed. Average national performance was worse than target. You can see the target there. So that's a signal that we need to improve things. And you can see there that we have work to do. And delayed discharges, or people who are stuck in hospital, should be out in the community, and the community services are not in place to look after them. And again, there's a clear signal there where you want the desired direction to be going down and it's going up. So this data means you can't hide. You can't hide from this data. So the next thing, so that quality profile is used with our board. We have a board of our National Health Service, and the Department of Health receive that. So and we publish it. So it's everybody can read it, everybody can see it, everybody can see how our performance is going. So much better off to share our problems than to keep them to ourselves. We also, with our board, we have a strategic scorecard, which against our service plan for the year picks out, in this case, 21 areas where we've committed to acting and to investing in. And then we produce we produce, sorry, I just got onto the wrong slide there. We produce a card against each of those priorities that looks something like this. It has a clear ambition statement that says, what are we trying to do in this area? This is the vaccination program against COVID. What are we trying to do here? Then in the rating and overview, we talk about what we're trying to do, the specific actions we're trying to take, the targets that we have. Then we have key performance indicators down the left. We have targets against which we're trying to achieve those, the number of people to be vaccinated. And you can see that we've achieved those targets in all instances. And we are introducing booster program at the moment as well, so that's been included. So that's an example of something that our board can see, and fairly readily it tells them, what target we've set and whether we're meeting it. We also then have a performance assurance report, which is essentially the subject of a quarterly meeting between our senior management and each of our hospital groups and each of our community healthcare organizations. There's a whole series of measures that people report against and can then, if you like, explain poor performance and work together, hopefully, to improve performance. So that's a whole area of performance management that goes on constantly throughout our healthcare system. So patient-reported outcome measures are something that we would really like to get to. They capture the person's perception of their own health through questionnaires. They enable patients to report on their quality of life, but also on the quality of their healthcare. It might help hospitals provide the kind of care patients need and that they want. And they fill a vital gap in our knowledge about our care, really. And I think it's something that we are really attempting to start to build into our system. So we've started some integrated care programs for older people, for example, to try to integrate care in the community and in hospitals better. And we're trying to include measures to see if this is effective across 5 domains around people's mobility, around their ability to look after themselves. Are they able to do their usual activities? What kind of pain or discomfort are they in? And are they suffering worry, anxiety, or depression? So this is a whole new outcome measure that's really based on experience. We don't have any data on that yet, but we're hoping to institute that in the coming year. And then our nursing colleagues have a whole series of further quality measures that help them measure the quality of nursing and midwifery care. And very specific practices in relation to safe practice and quality practice. And quotes from nurses and midwives in relation to this is, they feel that it's allowing them to look at their own practice and critically analyze it. And I think importantly to recognize the quality of service that they are providing. So it's not just about finding when service is bad, it's about saying, look, we're doing a good job here. It's the opportunity for nurses to create a safer environment and to lead on best practice. So very much welcomed by those who are delivering those indicators. But what about engaging staff in all of this? We have a staff engagement forum. We have all kinds of ways of engaging staff, but this is one that we have where we seek to systematically engage with people on their sense of where our health service is going. What do they think? What do frontline staff think about management decisions? Are they happy with the direction of travel? Because really what we believe is if our staff are not happy and listened to, and if they can't act on their ideas for improvement, then our patients won't be happy. They won't have a good service. A good service will not be delivered. So we believe in engaging with our staff. I think we could do a lot more than we currently do, but certainly it's something that my team and my division push for a lot. So we do a staff survey every year, and we just got these results, which are, I won't go through them in any great detail because they're very specific to our service. They give you a flavor of what we're measuring. To what extent does the organization value my work? That's a really key metric. Like if I don't feel my work is valued, will I really put in the extra discretionary effort to make sure it's a good job that I do? 40%, an increase from our previous, because we were asking the same questions over time, but 40% is an inadequate number. We would want 100% to say that they feel their work is valued. So really, that's an example of a metric that demonstrates a culture where people don't feel valued. And that's something that concerns me greatly. The opportunity to express my own ideas in my role, something again for somebody who's very invested in quality improvement, is really crucial. 62% felt they could. So that's a relatively good outcome, I suppose, and it has improved. So you can see a lot of the metrics are improving, but they need to improve a lot more. So this is a survey that we do to see how are our staff doing, what's the culture like in which they work in, and what can we do to improve it. And we get specific results for specific hospital groups and for specific community organizations, and I'll get the results from my own team. So I'll be able to work on my own team's culture in response to how my team rated the different measures. And these are some other examples, like my responses to my job are clear. My opinion is valued within my team, 69% agree, quite good. Be nice if everybody's opinion was valued within the team though. I have the necessary resources to do my job, that's lower. We always struggle with having enough resources, as every healthcare system does, to do the kind of job we want to do. So that's the kind of thing we're measuring in relation to staff. I better kind of accelerate a little bit here now, just coming to the end. We also measure patient experience. So that's, again, that's done in 2019. We're conducting another one this year. We conduct one each year. And this shows you a bit of an example of the kind of things we measure. How was your admission to hospital? Did you know what you were going in for? Were you treated with respect and dignity? What was your care in the ward like? 28% said that the food they received in hospital was poor or fair. So, okay, that means that 72% thought it was good. But you always, with every percentage, like even if 90% think something is great, you have to worry about the 10%. What happened with them? Why wasn't it great for them? So statistics can be a bit misleading that way, I think, sometimes. 96% of the hospital that they were in was very clean or fairly clean. That's quite good. We have quotes as well. So look, that's the kind of thing that we measure in relation to patient experience. And again, that's specific to each healthcare institution, and they can act on their own findings. They can compare their findings to the national average, and they can then improve care, hopefully, in relation to what the patients are saying. And this is another example of a more qualitative survey where people can give their view. There's all kinds of quotes in relation to what patients have been saying in different domains, what the health staff thought was best, what I really wanted, what services were available, and there's various examples there. Again, I can share these slides afterwards, no problem. So an awful lot about data, but what about stories? I always think, in a way, the data tells us what the situation is, and the stories tell us why. And they fill it out as well. They give us more of a kind of a sense of what's really going on. And why is the data in a certain, why are people dissatisfied? People, the satisfaction survey tells you if they're satisfied, and the story tells you why. So during this pandemic, we've been taking the pulse, if you like, of our frontline staff to see what their experiences of COVID has been like in frontline workers. I don't know if you've been doing this in India, but we're very aware that this is taking a massive toll on our staff. But very interesting but mixed kind of feeling. Some people felt very stressful, and uncertainty meant that tensions were running high in their team. But others felt like they were working really hard and putting a lot into it, that the results they were achieving were substantial, so they felt positive. They worked really hard, but they felt they could see something positive as a result. And what that reminds me of is, for our staff and for me, is all anybody really wants to do to have good morale is to go in the morning and do a good job and be able to do a good job. So management's job is to kind of enable our staff to do a good job and then get out of the way. That's what I think management's job is. And but a lot of talk about the intensity of the work, everything happening so fast. But myself and the team were thriving because people were empowered to make decisions and make them rapidly. And we made all kinds of very significant decisions in a room that I was in kind of very rapidly. And we weren't able to test whether it was going to work or not. We just had to make them because the situation was rapidly escalating and getting out of control. We then also, we did this thing, a kind of an epidemiology of kindness, which is kind of looking at people flourishing, which is this idea that we don't just, work is important to us. So we want our staff not just to go in and, feel relatively happy that they did a good job, but we want them to flourish. We want them to learn. We want them to use their skills and their strengths. We want them to feel that their time spent at work, which is an awful lot of your time, was time well spent, and that they feel better about themselves as a result of it. So we did this kind of qualitative interview process where people describe things during the pandemic of united we stand, divided we fall. So a real sense of teamwork, I think, can-do attitude, I felt included in my team and valued, supported, and listened to. If that could be said by every member of our staff, I think we'd have a really good health service. If that measure, if I had one measure to measure, do I feel included in my team? Am I part of a team? Do I feel valued and supported? And am I listened to? If every member of our staff said yes to that question, I think you would find you have a very effective healthcare service that patients really want to come into and feel cared for and looked after properly. So look at it shows that there are lots of important things to measure that don't just appear in data sets. That's what I'm kind of trying to say here. So Michael West is a professor in the King's Fund who we do a lot of work with, and he's really, what he talks about is distributive leadership, and it's something, again, that develops a culture where you get a yes to that previous question that I just posed, where leadership is distributed to the front line and frontline staff can deliver their own improvements. Summarize and to finish. Only measure what matters. Involve patients and clinicians in deciding what to measure, and only measure what's evidence-based. In looking at outcomes, try to move towards patient-recorded outcomes and their functional status, because we might discharge them from hospital, but they mightn't be able to walk. It's not a great result for the patient. So patient-related outcomes are going to be the future, I think. And don't just measure quantitative data, but ask people what they think. Look at qualitative data, look at interviews, look at people's views. Build capability for measurement, both ICT and staff capability. Use patient and clinical experience and expertise. Build data collection into routine work, so it's not an additional burden the whole time. Use the data that's already available. Measure once and use it often. Look for variability and look for trends over time. Seek transparency in measuring, so share everything that you have. Once you hide things, people start getting suspicious, trust breaks down, and people start looking for why you're hiding things. And really measure to try to create a culture of improvement and where we value our staff and where we're not going around blaming them and pulling them down. But if something is wrong, it needs to be fixed. That's really the message, I think, from Ireland. And thank you very much for listening. That's how to kind of contact us. That's our website, it's my Twitter handle, and our email address.
I just would like to quote a few words from your talk, like, all improvements will require change, but not all change will result in improvement. Another thing, measures only what matters to you. What do not matters to you, you need not waste your time in measuring. Again, trying to improve something, you can do it. Where you cannot do, don't try and waste your time. I think, and no data without stories, no stories without data. I don't know how we should express our thanks to you, because all these are very practicable. Ian Branson, one of the issues we often come across when trying to benchmark is truly comparing apple to apple. Often coders can act differently between organizations and different in nominators and denominators. Anything you can suggest that would help those trying to utilize benchmark measures that are truly comparable between organizations?
Excellent question. And it is definitely one of the pitfalls, isn't it, Dr. Mathai? You compare apples with oranges. So some people are using a different denominator. Some people are measuring, they're actually collecting the data in a different way. The only way really is to standardize, and the only way really to standardize is to train people together to agree how the data is collected, and then to measure equivalently. I can't see any other way. But the other thing, of course, to say is that once we find variation when we look at data, it's only the first part of the onion that we've unpeeled. Because what we have to do then, of course, is we have to explore with you. There may be a perfectly reasonable explanation for why one unit is very much worse than others. It may be a staffing issue. It may be a data issue. As you've just said, they may be measuring in a different way. One of the examples I have is obstetric hemorrhage. We've been comparing obstetric hemorrhage with different institutions because it's a measure of, obviously, obstetric care, the volume of hemorrhage. And what we were finding was that some people measured obstetric hemorrhage and they didn't really differentiate between amniotic fluid and blood. And it was just the amount of fluid that if you like, resulted from the birth. whereas others did. So then we were definitely comparing apples with oranges. So what we then moved to was a different measure. We measured the need for blood replacement, and that was a much more reliable measure, I think, of significant hemorrhage in obstetrics. So sometimes you have to just throw the measure out if it's too hard to standardize. Other times you can try and standardize.
Thank you. Now the next question from Pradeepa Pereira. How does one decide the denominator for the measurement?
Well, again, that's something you have to agree. Like, it depends on what level you're measuring at. It's like if it's a population measure, you decide what part of the population you're measuring, and then you work out how many people are in that denominator, and that's your denominator. In a hospital, you decide which types of patients you are seeking to include in your measure, which you exclude, and then you must agree that with all the other units. So everybody includes the same patients, and that gives you your denominator because you then only include the people who meet your entrance criteria. But that's a complex question, and it depends. It's quite context specific.
Okay, there is a doubt from Moisik. What is the appropriate period to analyze data using the SPC charts?
Well, that's a very good question, because obviously when you don't start an SPC chart until you have at least 6 months data, really. And the question then is, are you measuring it week by week? Or we generally measure things month by month, because there's an awful lot of noise week by week, whereas it smooths out a little bit month by month. So really, you wouldn't start acting on it until maybe closer to 9 months or so, that when you start to see more of a picture over time, and it gets more and more robust the longer you measure for.
I think the next is that Sheikh, in healthcare quality and safety, which one is your preferred, either continuous improvement or continual improvement?
I talk about continuous quality improvement. That's what I go for, continuous quality improvement.
Okay, now from Beena, how should we do the benchmarking? Who should be making the target and based on what?
Great questions, because sometimes you have a measure, and management come in and say the target is 100%, but the people working in the area say that's ridiculous. You haven't given us any resources. We haven't a chance. We're only at 60% at the moment. So you set a target then that isn't a stretch target. It's a target that demotivates people. So how do you set a target that's reasonable? Well, you should be setting a stretch target. There's no point in setting a target that you're already meeting. So then there's no point in doing anything, because you're already meeting the target. So you set some kind of an intermediate target that has to be agreed, I think, with the clinical community and with patient representatives. That's how you come up with a target that is, I think, reasonable and that people accept, and that you might have a chance of meeting, but that do stretch you.
Yes. From Ivan, a lot of measures you have displayed are things you can measure immediately and see benefits immediately. We know this is much more difficult when trying to improve population health. Any thoughts or suggestion here?
Yeah, I mean, because the health and well-being director is in my team now. I'm responsible for health and well-being in our health service, and we have a Healthy Ireland program. And so what we do is we do surveys to see, is smoking increasing? Smoking cigarettes, is it increasing or decreasing in our society? Is obesity increasing or decreasing? Levels of exercise, are they increasing or decreasing? Because we have all kinds of programs, both in terms through the media, through doctors and nurses, a thing called Making Every Contact Count, where we try and we understand that when somebody comes in to see any of us as clinicians, they're more likely to change their behavior because they're more concerned about their health. So that's why you say, make that contact count, by not just looking after the illness that comes in, but by saying, have you thought about stopping smoking? Or how's your exercise? Do you get 60 minutes, 30 minutes a day, even moderate exercise? So those kind of things we measure through surveys.
I think the other question, thank you for your exciting lecture. I have one question. Which do we use best clinical indicators, as outcome measure, process measure, or balancing measure, or all? I think it's all depend upon the situation what we have to do, so we don't waste much time into that.
No, but what's good is that balancing measures has been mentioned, because that deals with tunnel vision, where you just measure one thing and then something else is going right. We need balancing measures, but yes, I would say all.
any view on culture of reporting around a healthcare facility?
Yeah, I mean, really, if a facility doesn't want to report on its services, it suggests, if there's a lack of transparency, that means to me that I would be worried about that facility, and I would want to sit down and talk to them about what are they afraid of? Do they feel their performance is poor? Can we help them improve it? And not to be afraid of transparency. So I think a culture of reporting is critical to the whole culture of the organization, and transparency is the only way to go.
The next question is, I think that clinical and non-clinical indicators are important for continuous improvement. Please, what's your opinion?
I agree completely. A lot of the things we measure are not clinical. For example, in the patient experience survey, if people don't like the food they're served, they won't eat it. Then they will become more malnourished when they're in hospital, and they may be malnourished as a result of their illness already, and their likelihood of recovery is greatly reduced. So it's not a clinical indicator, but it has clinical effects. So yes, I think both are important.
Once again, thank Dr. Philip for that wonderful presentation. I think you did your job best.
As a token of our appreciation, I would request Dr. Ravindran Jagaswati to present to our speaker a small certificate from CAHO. Over to you, Dr. Jagaswati.
Thank you. Dr. Philip Crowley, you did an excellent and brilliant presentation. I think you can gauge it from the amount of questions you had to field. And I think that's a commendation of everyone concerned, that they have imbibed whatever you said about measurements and all the quality indicators for quality improvement. Thank you so much, Dr. Philip Crowley, and it's my pleasure to present to you this certificate of appreciation on behalf of CAHO. Thank you.
And it's my honor to receive it. Thank you, Dr. Jagaswati. Thank you very much.
Thank you all, dear participants, for joining. This is the last program for this year, and wishing you all a very Merry Christmas and a Happy New Year.